Hello, my name is Jeff Hauk, and I want to acknowledge my co-authors at Upstate Medical University in New York, George Fox University, and University of Rochester. And the title of this talk is PROMIS in Biopsychosocial Care Evolving Lessons. My disclosures is I have a training site, beyondbiopsychosocial.com, where we provide training on psychosocial issues. So this talk is really about what it means to look at a person through a different lens for just a minute or two during the evaluation. And what gives us this different look is the PROMIS measures. So PROMIS stands for Patient-Reported Outcome Measurement Information System, and it's their self-reported outcome, but what's different about these particular outcomes is that they're person-centered, that they cover physical, mental, and social health measures, so lots of different outcomes in these different health domains, and then the reference to the general population. So what this means is that the questions or items aren't disease specific, like the foot and ankle ability measure or another disease specific measure that we typically see, but rather they're person centered, so they never mention the disease. So you're getting a look at their overall ability, not just how their foot is working or something like their back is working. And we'll kind of expand this discussion on the different scales that are available in the physical, mental, and social health domains, but there's many scales available through PROMIS in these different domains. And then finally, the scale references the score to the general population by using data from the U.S. Census or another reference population. So a 50 means that the person's equal to the average of the reference population, usually the U.S. average. And a 10-point score higher means they're one standard deviation better than the average, or a 10-point score lower means they're one standard deviation lower than the U.S. average. They're also computer adaptive, and what that means is that for each health domain or each outcome that you use, it only takes about 1 minute, and you get a score. So this makes the patient burden in taking these different scales low. It also means that you can test people who have really high ability, moderate ability, and low ability without having floor and ceiling effects. And finally, if you want to, you can look under the hood and see exactly what a T-score means. So instead of just getting a score from the average, that's plotted here on the y-axis, and this is an example for the physical function scale. You can also take a look at what an individual T-score means. And so a 40 is a pretty common score we're going to talk about in this talk. And so we can see on the physical function test what this means relative to sit to stand, walking, and stair ascent. And in this particular graph, what we've done is color-coded blue as a response that means there's no difficulty with that task, and the maroon means that they're unable to do the task, and then these kind of colors in between is grading from unable to no difficulty. And we can kind of see is that we draw the line across at 40, we have these different sit-to-stand tasks, and for the most part, they're either in the green, so little difficulty, or blue, and then for walking, it's the same, so if they score 40, for walking around the house at a normal speed or walking briskly, there's some difficulty, but then if you have to go for a hike for a mile, that's difficult. And then for stairs, we can kind of see here, they kind of blew these up. So, the up and down stairs at a normal pace is not too bad because it's in the green, so just a little bit of difficulty. But climbing up 5 flights or climbing up the stairs of a 10-story building, really not able. So a 40 has meaning relative to a person's perceptions of these different items that they've kind of responded to in this, and you can also have access to that information if you want to inform your clinical decision making. And then finally, you can aggregate scores. So as a team, you can aggregate these scores and plot them to look at either the severity of patients that you're treating or some kind of response that you're looking at. So here I'm showing you physical function again. This is where the normal distribution or the U.S. average would lie, and these are people that at their initial evaluation at one of the clinics I was working at. And you can kind of see that the graph is shifted to the left, meaning that the lower scores here on the left, so the patients are a little worse than average. And on average, it's their 0.6 standard deviations worse than average or lower than average, and that's their normal curve. And you also know that you had a small segment of patients that were above average. So the needs for your practice are to cover both people that have low physical function, up to 3 standard deviations below average, and then also some unique group of patients that are above average at the intake. Okay, so that's what PROMIS gives us. They give us this different look at how people are functioning overall, not specific to a particular joint or problem. It references the US average, and it also can be done quickly and has few floor and ceiling effects, so it can be applied across a large population with different abilities or symptoms of that particular health domain. So the most typical ones that have been used in foot and ankle, though, are physical function and pain. So let's take a look at what we know about those so far. So here's a study that I was involved with at the University of Rochester that was about looking at 2 concepts. The first concept was the patient acceptable symptom state, which is essentially asking the person to answer if their symptoms are really, kind of good enough, but not gone, but are they low enough that it's acceptable to them? And that's kind of a yes-no question. And the PROMIS scales correlate really well with this particular concept. Another concept, though, that seems really similar is when you ask a patient to judge success or failure from surgery. And essentially, in this particular example, this study sample, about 80% said that their surgery was a success. But when we think about whether an acceptable symptom state and success from surgery are the same, there was a clear distinction in the study. And essentially what we're going to say is they're not really equal. So what happened was about half of the patients that said they had an unacceptable symptom state, about half of those patients said that they had success from surgery. And so what does that mean? Like, how would you rectify that? Well, typically when we're talking about treatment or we're negotiating how a patient's going to participate in recovery, either what they expect to get from surgery or what they expect to get from rehab, we set expectations, which is like a contract with the patient. And if that contract's met, even if the outcome's unacceptable, if that outcome's met, then the patient will still judge their treatment with you as a therapist or their treatment from surgery as a success, even though their health status is not really adequate. And so when we're looking at PROMIS scores, we're really looking at health domains, which correlate more toward the patient acceptable symptom state than they do success. So the other thing we could look at and take the same concept of patient acceptable symptom state, we could ask whether or not economic status matters to determining what's acceptable to people. So we did here is we had 3,000 people from urban area at their initial intake for a foot and ankle surgical consult, and we had about 20 to 30% were acceptable symptoms and 70% unacceptable symptoms in the sample. And we asked the question of whether or not people at high income, if their threshold for an acceptable symptom state was different if it was high or low income. And in fact, it was. Patients with high income defined an acceptable level of symptoms and function on the pain interference and physical function scale at a 50, where people at low income defined an acceptable level of symptoms and function on the pain interference and physical function scale 1 standard deviation worse than the US average. So here we have this clear distinction between what people will accept just based on income. And so by looking at the PROMIS scores, it would help us identify people who, when they're at close to the US average rather than surgical intervention or a high intensity rehab program, what they may need is reassurance or self-management, versus people that have low scores on the physical function or pain interference scales. Now we're talking about intervening more with them because we know that they have, this kind of low level of functioning. So, and it helps us not pay attention to economic status and those kinds of variables. So now I want to show you, a backdoor look at some of the research that we do. So we'll start with a procedure that's widely accepted as successful. Ankle fusion surgery has been very effective for years and different outcome studies. And so if we look at physical function, what we might expect is something like this. And these are data from one of the data sets I had worked on. And we can kind of see here's the physical function scale on the Y. And we can kind of see the U.S. average here, and then the 40 below the U.S. average. So most of the patients getting surgery are at or below the U.S. average. And then we can kind of see this typical recovery pattern where the blue line represents surgery. So this is pre-surgery over here and post-surgery to the right. We can kind of see this recovery pattern. This is kind of what we expect clinically, but I've really cherry-picked this data set. And so what do you think it would look like if we looked at just all the patients that had this procedure in clinical care? Like what would be the reality of how this gets delivered? So this is going to be the real data before it's filtered for kind of the ideal patient or the appropriate exclusion inclusion criteria, as if when we typically publish this kind of data. And so this is the same graph, and you can kind of see here's the pre-surgical patients, but look at the post-surgical recovery patterns across all the patients. And this is really the difference between our beliefs and expectations, which we saw in the previous graph, where we're thinking, hey, this is a good procedure, everybody's going to recover. So our willingness to kind of, provide this procedure for many patients, but this is the outcome of just unfiltered data. And so looking at this kind of aggregate data, would be really helpful. There could be real good reasons for different, kind of outcome trajectories that we see on here that may be appropriate. But there's also clear that not everybody is having this kind of really standard improvement from this procedure. So here's the paper that we published based on that data. And we can kind of see this is the physical function. So this is after we've kind of cleaned the data and made sure that the people that are being evaluated in this particular data set of 88 patients is appropriate and the correct use for this particular procedure. And we can kind of see here is on the y-axis is the physical function, and here's the U.S. average. And then here we plotted the acceptable symptom state thresholds. And we can kind of see that really in terms of physical function, patients are starting quite low. They have this kind of recovery pattern, but they really never get on average into that acceptable range. Now, if we look at pain interference, we can kind of see here the same thing. We have the x-axis here. Here's our reference to the U.S. population and the acceptable symptom state. And we can see that the pain initially is 1.5 standard deviations worse than the U.S. average, so quite high pain in supporting the use of the surgical procedures that they received. And then their recovery really puts them in that zone of an acceptable level, and so still above the U.S. average, but really at an acceptable level. So the procedure really is in a good way. It kind of has a response for pain, but there's still room for improvement in terms of physical outcome. Now, this is relative to patients recovering from many different problems that are going through rehab. So it's 352 patients that were seen in rehabilitation. And what we plotted here on the X is we broke patients into bins based on their level of severity at their initial encounter in PT. And then we calculated essentially their change over time to their discharge from PT, so the end of PT. And then what we did is we said, okay, so let's put the percentage of people in green that improved a half standard deviation or more. In vanilla, it's patients that didn't improve, and red, it's patients that got worse. So what we can kind of see is worse baseline severities over here to the left and better baseline severities to the right. And we can kind of see is that PT, the green indicates improvement and success really. And so the patients that really improved were ones that were low at the beginning, and we got gradually less effective as we got closer to the US average, or 50. And then once we got above 50, we were less effective. And of course, there weren't as many patients there, but essentially we weren't really addressing those patients' needs either. So this kind of aggregate data gives us a better look at how to direct and change our care than just trying to theorize about who needs what kind of care, that based on diagnoses and other things that we're focusing on. So beyond looking at aggregate data and looking at very specific health domains, is it beneficial to change our approach and start to expand to psychosocial domains and not just pain interference and physical function, which are really physical health domains? And so there's a lot of PROMIS scales in this biopsychosocial categories. And so this talk isn't really going to explore that, but there's a lot of possibilities in terms of expanding to psychosocial experiences that our patients are having. And a good reason to engage in this is there's many studies, this just being one of them, showing that when patients try to judge emotional stress that patients are having, or providers try to judge emotional stress that patients are having, they're really not very good at it in terms of like matching whether the patient has or doesn't have depression. Judgments by providers are really not accurate. And if you ask patients or providers to judge whether patients are at risk for persistent pain or not, they're really not that accurate. Okay, and so using measures can either help your accuracy because you learn, or you can rely solely on them to determine, what the, mental status or what kind of, negative or positive health status, psychosocial status your patient's experiencing. This is an example specific to the hallux valgus. We ask problems. We ask the question: are psychosocial outcomes as important as physical impairment in determining a patient's perception of physical function and pain interference? So the idea is that we would correlate objective measures of range of motion and strength with physical function and pain, and then we'd also correlate kind of psychosocial outcomes with physical function and pain and see if the range of motion and strength had the same weight or correlation, like R values, as kind of psychosocial measures. And so here's kind of our objective set of physical function measures. So we have the MPT flexion, so how strong are the flexors of the big toe. A paper pull test is another strength test for the big toe. And then we had like a combination of calf strength and range of motion by looking at the heel rise test. These are all using instrumented lab-based data. And then we compared that to fatigue, self-efficacy, and satisfaction with social roles. And I'm really only going to show you the self-efficacy of symptom management scale here. So here's the correlations with physical functions. So we have physical function on the Y and first MTT strength on the X. We can kind of see, kind of a moderate correlation, meaning that as expected, physical function was lower when strength was also lower. And then also heel rise height. So when heel rise height was better, then basically physical function was also perceived as better. So good connection between physical ability and what we focus on to improve physical function or perceptions of physical function in patients. But here's the psychosocial measure of self-efficacy, and we see self-efficacy, see here's the predictor of physical function on the X. And in this particular data set, which is about 24 patients, we can kind of see that really the psychological variable of self-efficacy had a higher correlation than these objective measures that we use. So meaning that essentially this psychological scale had just as much impact on a person's perception of their physical ability as their actual capacity. And this was similar for the pain interference scale. And finally, I'm just leaving with another aggregate data set for this particular talk. So, what's the benefit of really looking at a whole host of different psychosocial outcomes in an important procedure like total ankle? So again, another kind of end stage, joint procedure for the ankle. This was data from an internet survey, so the sample is not random, but of those who accessed the survey. So this is about 96 patients that accessed the survey that had a total ankle replacement. And they completed the PROMIS 29, which includes 7 different outcomes, which is, from left to right: physical function, depression, I guess is purple here, sleep is disturbances, the blue, social participation is red, anxiety is this kind of brown color, fatigue is yellow, and then pain interference is this kind of off red color. And so what we can kind of see is that the U.S. average here, and most of the 5 of the 7 scales are close to the U.S. average, and then 2 significantly lower than the U.S. average, and those would be the physical function scale, is really, the median is right at 30, which is very low, 2 standard deviations below normal. And then the red is the social roles and satisfaction with social participation, right? And we can kind of see that this is also in the 30s, so over a standard deviation below the U.S. average. This is after 17 physical therapy visits, and this is a 3-year follow-up. So what this kind of aggregate data would give us it gives us a different look at patients and gives us this kind of idea of like what is the problem of these different kind of self-reported experiences the patient's having. And we can kind of see that physical function really hasn't been improved dramatically at this particular follow-up for this sample of patients, and that it's impacting not these kind of mental health scales, but really their social scale is the one that's the most highly impacted. So this could potentially direct care to kind of look into these kind of problems with these patients in an attempt to improve their status with social participation and physical ability. So hopefully this talk has helped you understand what exactly PROMIS is and how to interpret the scales, a comparison between acceptable symptom state and success, how economic status might influence PROMIS thresholds for acceptable symptom state, the influence of baseline severity on physical therapy encounters, and then what advantage there might be to looking at aggregate data, and the possibility of expanding to psychosocial scales. And finally, this Picasso is really more representative of what our patients are than some kind of two-dimensional impression of their experience with healthcare. And hopefully this talk kind of motivates us to try to explore that as part of our clinical care.